Hello everyone, welcome back to Tutor Series. My name is Shujauddin and today we're going to be talking about peptic ulcer disease. So when we say ulcer, we need to know what ulcer is, right? So there are two medical terms. So let's get them right out of the way so that we can understand this whole topic. So the first term is erosion. When I say erosion, erosion means loss of your superficial surface. Like superficial mucosa is going to get damaged, and that is what we call erosion. Now when I say ulcer or ulceration, that means that I'm going deep inside up till your muscularis mucosa or even farther than that. Muscularis mucosa or more than that, when that layers come into the damage and they get damaged, that is what we call ulcer. So erosion is superficial, ulcer is deep. How deep? Even farther than your muscularis mucosa. So when we say peptic ulcer disease, it's simple, the damage is beyond your muscularis mucosa, right? So before we talk about what happens in ulcers and what are the different kinds of ulcers and how to manage them, let's talk about our physiological protective factors that our body has. So for that, you need to know that in our stomach we have two things that are very important. We have gastrin that is released from your antrum, and we have parietal cells in the stomach's fundus and body. What does gastrin do? Gastrin acts on your parietal cells and stimulates your parietal cells to produce what? I mean, the most important thing in our stomach is hydrochloric acid, right? I mean, it's famous for its acidic medium that comes because of its HCl, right? So parietal cells have a hydrogen potassium ATPase pump on which gastrin acts and produces what? HCl. Gastrin acts on parietal cells produce HCl. This is how normally acid gets released. Now obviously, I mean, that acid can always harm our stomach. So how does our stomach stay safe? So there are a few things that are present in our stomach to protect it from the acid. So the first thing that we have is bicarbonate ions. We have bicarbonate ions present in our stomach that neutralize the acid when it comes into contact with the stomach mucosa and does not damage our mucosa. So we have bicarbonate ions. Now the second thing that we have that protects our mucosa is basically your mucus production. That is your foveolar cells produce mucus so that it can form a layer and acid does not come into direct contact with your stomach mucosa. So we have foveolar cells that are protecting your stomach mucosa by making mucus and lining your stomach mucosa and protecting it from coming to direct contact with HCl. The third thing that we have in protection is basically your blood vessels. Blood vessels take away the leaked acid that is present inside your stomach. So when it takes away the leaked acid, you don't have a lot of acid inside the stomach, hence it won't damage your mucosa. So you have blood vessels. That is how your stomach stays protected from the acid, because increased amounts of acid can cause peptic ulcer. It's simple. So anything that decreases your amount of acid inside the stomach is going to protect you from developing peptic ulcer disease. Simple. And the three things are bicarbonate ions that neutralize the acid, foveolar cells that make mucus lining your stomach mucosa, and blood vessels that take away the leaked acid, hence you don't get peptic ulcer. Now, before we move on to the causes, there are two kinds of ulcers. I mean, when I say peptic ulcer, it could either be in the stomach or it could either be in your duodenum. If it's in your stomach, its favorite position is the lesser curvature. I mean, if I were to draw a stomach over here, if this is your stomach, right? If this is your stomach, so this will be your lesser curvature. I mean, if we talk about the anatomy, this is your greater curvature, right? And this is your lesser curvature. So when we talk about peptic ulcer in your stomach, the favorite position for ulcers is going to be your lesser curvature. And if we talk about ulcers in your duodenum, their favorite position is going to be the first part of your duodenum. Your duodenum is divided into three parts. You have a first part, the second part, and the third part. So it affects your first part, and in the first part, it could either affect your anterior wall or your posterior wall. Now, why did I say anterior or posterior? Because the position, be it anterior or posterior, comes into significance when we talk about our complications of peptic ulcer disease. So keep that in mind, and I'll talk about it when we discuss complications. So ulcer either in your stomach or in your duodenum. If in the stomach, it's going to be your lesser curvature. If in the duodenum, first part of your duodenum, either the anterior wall or the posterior wall. Now let's talk about the causes. That what causes your ulcer and what are the risk factors that increase your chances of having ulcers. So the first cause that is very common and is like, everyone knows about it is H. pylori. H. pylori, Helicobacter pylori, is basically a bacteria. It's basically a comma-shaped bacteria that can cause peptic ulcer in a person. So we have H. pylori right here. The second most common cause is going to be NSAIDs. NSAIDs are non-steroidal anti-inflammatory drugs. So people who take NSAIDs on a regular basis due to any predisposing condition or existing condition, they can end up getting peptic ulcers. NSAIDs. The third common cause, I mean not common, but yeah, the third cause is ZE syndrome, that is Zollinger-Ellison syndrome. Now we're gonna see over here that how do these cause ulcers, but I'm just listing down the causes here. So these are your common causes. Apart from that, you have a few uncommon causes as well. That is people who are stressed, I mean who take a repeated period of stress, they can also develop ulcers. I mean mental stress, be it could be anything. I mean if we talk about students, we have exams, as medical students we have to face a lot of exams. So yeah, even we can get ulcers. So the risk factors, I mean, could be stress. Apart from that, a few common risk factors that you should be working on are smoking. First thing, smoking can promote ulcer. Apart from smoking, high amounts of caffeine. High amounts of caffeine, and thirdly, high amounts of alcohol, that is alcohol consumption. The ones in red can promote you, and the ones in blue are basically the causes. If you smoke and you also use NSAIDs, it's only going to double the risk. If you use NSAIDs and you also drink coffee, it's only going to double the risk. If you take NSAIDs and also consume alcohol, it's only going to double the risk. So the first thing is that we're going to talk about H. pylori in the stomach, then we're going to talk about H. pylori in the duodenum, then we'll discuss NSAIDs, and we'll see how Zollinger-Ellison syndrome causes ulcers, right? So we have stomach, and in the stomach we have H. pylori that is causing our ulcer, right? Now let's see how does it cause ulcer. So you have two things that are characteristic of H. pylori. The first thing is urease, and the second thing is CAG-A. CAG-A is basically a toxin that H. pylori has. Now what urease does is, it is going to break down your urea into ammonia. So ammonia is a weak base, I mean all of you know that, right? So what urease is going to do is going to break down urea into ammonia, NH3. Now this ammonia is going to interact with what? I mean we're talking about the stomach, right? So this ammonia is going to interact with your HCl. Now when a weak base interacts with an acid, you have a partially neutralization reaction happening. So if I were to have an initial pH of, let's say, 1 in the stomach, and then I added NH3 and it's going to combine, so what do you think is going to happen? Your pH is going to increase, it's going to go towards the alkaline medium, right? So urease converted urea into ammonia, and ammonia made a alkaline medium in your stomach. Now that alkaline medium is going to allow for the proliferation of H. pylori here. This H. pylori is going to grow much more and in a much better way in an alkaline medium. So you're basically providing a breeding ground, right? Now, due to high amounts of H. pylori, you will also have high amounts of CAG-A toxin that is going to be present on each and every H. pylori organism. And this CAG-A is going to disrupt your stomach mucosal lining. Now, when you have a toxin that is disrupting your mucosal lining, what are you going to end up with? Ulcer, right? So, a combined effect of urease and CAG-A are going to lead to ulcer development in your stomach, because H. pylori's amount is going to increase and you will end up with an ulcer in your stomach. So this was H. pylori in the stomach. Now let's talk about H. pylori in the duodenum. Now what happens that in the duodenum you normally have an alkaline medium, right? I mean, your stomach is acidic, but your duodenum is alkaline in nature. Now when you have H. pylori in the duodenum, what it does is it inhibits your somatostatin. So let's talk about somatostatin for a bit. Somatostatin is a inhibitory peptide hormone. It inhibits a lot of things. To name a few, is going to inhibit your growth hormone, your thyroid hormones. It's also going to inhibit gastrin. Now, in my video earlier, I talked about gastrin promoting acid production by acting on your parietal cells, right? Now, if I have somatostatin inhibiting gastrin, so eventually what's going to happen? Your duodenum is going to have a alkaline medium because gastrin is inhibited, and with gastrin inhibited, you won't have any HCl in the duodenum. So it's going to be completely fine. A duodenum will have an alkaline medium. But if you have somatostatin inhibited by H. pylori, if I inhibit this, would you have gastrin inhibited? No. You will have a high amount of gastrin in your duodenum. Now, what is gastrin going to do? It is going to act on your parietal cells and lead to HCl production and lead to an acidic medium in your duodenum. But that's not okay. It's not healthy for your duodenum to have an acidic medium. With the acidic medium, you will have hypertrophy of your Brunner's gland that are present in your duodenum, and your carbonate that is going to maintain the alkaline medium is going to decrease as well. So what's basically happening? You have high amounts of HCl in your duodenum and low amounts of carbonate. So you guys can see with this, you will have an acidic medium in your duodenum, and this is going to lead to ulcer production in your duodenum. So this is how H. pylori is going to cause an ulcer in your stomach or in your duodenum, but it has two different methods. It has a different method in your stomach and a different method in your duodenum. Have a look at another cause that is very important. NSAIDs. NSAIDs are an important cause in causing ulcers, and we have a lot of conditions in which people use NSAIDs over a long term. It could be anything, like let's say if I were to give you an example of a 60-year-old woman. She's obviously postmenopausal, and she comes to you with joint pain, like she is having joint pain over a course of, let's say, 6 years. So obviously to kill her pain, you prescribe her NSAIDs. So people using chronic NSAIDs for any condition can end up having ulcers. So let's talk about NSAIDs and how they contribute to ulcer production. Now, NSAIDs are basically inhibitors of cyclooxygenase 1 and 2. NSAIDs inhibit COX-1 and COX-2. Now, you have COX-1 and COX-2, and these are going to be inhibited. Now, COX-1 and COX-2 are responsible for your prostaglandin synthesis. I mentioned earlier in the lecture that prostaglandin is responsible for your protection of your stomach, and it prevents ulcer formation. How does it do that? I'll just briefly go over it. It increases your carbonate, it increases your blood supply, and it decreases your amount of acid. All of these factors are going to lead to prevention of your ulcer. Now, if I give a person NSAIDs, and if I give them a substance that is going to inhibit their prostaglandin synthesis, what's going to happen? You won't have prostaglandin E2 left to protect you anymore, and with low amounts of prostaglandin you will have higher chances of developing ulcers, right? So this is how NSAIDs produce that. You will have low amounts of prostaglandin E2, and you will have no protection towards ulcers, and you will end up having ulcers. So this is how NSAIDs lead to ulcer production in your stomach. Now, coming on to ZE syndrome. ZE syndrome is Zollinger-Ellison syndrome. Now, what happens in ZE syndrome is that you have a gastrinoma. What do I mean by gastrinoma? You have a tumor that secretes gastrin, uncontrolled high amounts of gastrin. That is what happens in ZE syndrome. So if I were to write high amounts of gastrin here, what do you guys think would happen? I mean, we just talked about gastrin over here. High amounts of gastrin will lead to increased amount of parietal cell stimulation, and high amount of stimulation towards the parietal cell, you will end up having high amounts of acid, and acid is always dangerous. It always leads to ulcer productions, which is why prostaglandin reduces your HCl amount once you're done with your digestion, so that you don't have ulcers. But if you have uncontrolled amount of gastrin, because you have a tumor secreting gastrin, so high amounts of gastrin, high amounts of acid, and you will be prone to developing ulcers. So this is how ZE syndrome causes ulcers inside your body. Now, to discuss a particular type, that is stress ulcers. Stress ulcers are a type in which you develop ulcers inside your stomach. Now, you have two different subtypes of it. First is curling ulcer, and the second is Cushing ulcer. Curling ulcer happens in patients or victims, I would say, who have burns on their body, who have been burned. Now, due to burn, they will have hypovolemia. Obviously, they're going to lose blood, they're going to lose water from their body, hence they'll end up with hypovolemia. And earlier I mentioned that blood is responsible for taking away leaked amount of acid from your stomach, right? Now, in patients with hypovolemia, when you have low amounts of blood, you won't have blood readily available to take away all the leaked acid. So what are you going to end up with? A stress ulcer that would be of the type of curling. So curling ulcer develops in patients who have been burned because of hypovolemia. So curling ulcer. Secondly, we have Cushing ulcer. Cushing ulcer basically happens in patients who have increased amount of intracranial pressure. It could be due to any neurological cause. Now, how can high amounts of intracranial pressure lead to ulcers? What happens is that high amounts of intracranial pressure are going to lead to vagus stimulation. Now, when you have vagus stimulation, there are different methods of releasing HCl in your body. One is through gastrin, one is through H2 receptors, H2 histamine receptors, and thirdly, due to vagus stimulation leads to acetylcholine release, and acetylcholine leads to your acid production. So high amounts of intracranial pressure, vagal stimulation leads to acetylcholine release, and acetylcholine is going to lead to acid production. So that is going to be your Cushing ulcer. So it, in either cases, in patients who have been burned or in cases where you have high amounts of intracranial pressure, you can end up with stress ulcers. So people who have been admitted in the ICU, stress ulcers are very much common in them, which is why they are usually given proton pump inhibitors or something to prevent ulcers from that. So we talked about the mechanism, we discussed the causes over here, and then we talked about the mechanism, how H. pylori and say ZE syndrome are going to lead to ulcer in a person's body. Then we briefly talked about stress ulcers. So let's talk about the symptoms, right? So the first thing that is very much common is epigastric pain. Now, epigastric pain is common in ulcers, and where does this happen? It is basically pain above the umbilicus. Above the umbilicus is your epigastrium, and in that region, like it will be very localized, just right here, and you will end up having epigastric pain, right? So, epigastric pain is common that every patient is going to complain of. Apart from epigastric pain, you will have other symptoms such as nausea, vomiting, indigestion. So yeah, nausea, vomiting. Now, one thing in the symptoms that can help you identify whether the ulcer is of gastric origin or duodenal origin is when does the pain occur. That is of very significant importance. So, if I were to say that when I eat, pain increases, that means that the ulcer is of gastric origin. Gastric ulcers are going to have increased pain on feeding. Now, why is that? Why do they have increased amount of pain? When they eat, more amount of acid is going to get released, right? Your stomach mucosa is going to produce more amount of acid because you are now eating, you have food in the stomach. High amount of acid is then going to irritate your ulcer, and you'll end up getting epigastric pain after you eat. So patients who have gastric ulcers, they won't eat much because every time they eat, they're going to have pain, and not eating is going to cause weight loss. So patients with gastric ulcer are going to come to you firstly with the history of pain after eating and weight loss. The opposite is going to happen when you have duodenal ulcer. Your pain is going to decrease on feeding. Because every time you eat, your duodenum is going to increase the amount of bicarbonate, because in the duodenum you have high amounts of bicarbonate when you eat. Obviously, the duodenal secretions are alkaline in medium, and high amount of bicarbonate is going to neutralize the high amount of H plus, right? I mean, what did we say? In the duodenum, you will have high amount of HCl normally and decreased amount of bicarbonate. But when the patient of duodenal ulcer is going to eat, they will have high amount of bicarbonate because food is going to stimulate your duodenum, the Brunner's gland in your duodenum, to secrete bicarbonate, and alkaline medium is going to form, and the patient will say that I have decreased amount of pain when I eat. So when the pain gets decreased on feeding, these people are going to eat more and more because that is basically reducing their pain. So what's going to happen? Such patients are going to come to you with weight gain, right? Now, with this, one thing that you need to know is that you also have nocturnal pain. You have increased amount of nocturnal pain in duodenal ulcer, and you have decreased amount of nocturnal pain in gastric ulcers. So nocturnal pain, I'll write this down here. High in duodenal ulcers and low in gastric, right? So these are going to be your signs and symptoms. Now, coming on to the investigation, you have a patient who has peptic ulcer, right? I mean, given the clinical history, you now know you're suspecting them of having duodenal ulcer. Ulcer, just peptic ulcer. Now, you don't know where it is and all, but obviously, depending on the history, you might be able to localize, yeah, if there is increased pain on eating, gastric ulcer, decreased pain on eating, duodenal ulcer, right? Now, how would you investigate? So, the first thing is you're going to go cause by cause. So, if you think that the patient has H. pylori, so what are you going to do? You're going to order tests for H. pylori, that are going to be your urea breath test, for H. pylori. This is how you can catch H. pylori. Apart from that, you will also check for fecal stool antigen, fecal antigen for H. pylori. These are non-invasive tests. What would be the invasive test? Go for a esophagogastroduodenoscopy, EGD. Esophagogastroduodenoscopy is your confirmatory test to see where is the ulcer and what is the cause of it. You can identify this because through this esophagogastroduodenoscopy you can also take a biopsy sample to see what kind of ulcer do we have, right? You can easily take a biopsy, and through that biopsy you can then do PCR. You can also do invasive tests and see whether the patient has H. pylori or what that is causing the ulcer. So you can do a esophagogastroduodenoscopy. This is your confirmatory test. Confirmatory test. Apart from this, you can, obviously, if like I mentioned, let's say you have a postmenopausal woman, 70-year-old, coming to you saying that I have epigastric pain. You're going to take their history. They're going to tell you, yeah, they have been taking NSAIDs for around 20 years. So I mean, you really know that this is exactly why they're having ulcers. So you're not going to suspect H. pylori. So it's only going to reduce your hassle. So this is basically a brief investigation as to how you go up. So I'll basically write this down here for you guys, that duodenal ulcers are always benign, right? So duodenal ulcers, benign, always. While gastric ulcers can be malignant or benign. Now, what do benign ulcers have and what do malignant ulcers have? So benign ulcers will be smooth, they'll have a smooth surface, they'll be round and regular, right? This is what a benign ulcer is going to look like. And if I were to talk about malignant ulcer, now malignant ulcers will be rough, completely opposite of benign, rough, irregular in shape. So, and gastric ulcers can be benign or malignant, but you'll always have benign in duodenal ulcers. So let's talk about the treatment of peptic ulcers, right? So like I said, a patient has peptic ulcer due to NSAIDs, you just tell them do not take NSAIDs, stop their NSAIDs there and then, right? But if they have peptic ulcer due to H. pylori, for H. pylori we have triple therapy that we follow. For H. pylori, we follow triple therapy. Now, what do we give in triple therapy? The first thing that we are going to give them is going to be PPIs. PPI is basically your proton pump inhibitor. What do PPIs do? They are going to inhibit what? Hydrogen potassium ATPase. Does this ring any bells? I mean, did we discuss hydrogen potassium ATPase? Yeah, we did. Hydrogen potassium ATPase was present inside your parietal cells producing HCl. So if I give someone who has peptic ulcer due to H. pylori, if I give them proton pump inhibitors, what are they going to do? They are going to inhibit that very pump in the parietal cell that allows for the formation of HCl, right? So I'm going to reduce HCl production. So reducing acid production, always good to protect you from ulcers. Secondly, what can I give them? I'm going to give them antibiotics because like I said, H. pylori is a bacteria that can allow, it's a bacteria, so obviously you're going to give them antibiotics to treat it. What are the antibiotics? Amoxicillin and clarithromycin. Amoxicillin and clarithromycin. These are two antibiotics that you're going to give them to treat H. pylori. Now, if you're reducing acid, I mean, why do you have to give them antibiotics? Like, I mean, you're saving them. No, you're not, because H. pylori has CAG-A that it releases, and CAG-A is what damages your mucosa. So you need to get rid of this monster here. Yes, this, you need to get rid of it. What are you going to give them? Amoxicillin or clarithromycin to treat H. pylori, because H. pylori, if it dies, that is when CAG-A is going to reduce, and CAG-A is basically what disrupts your mucosa, right? So you treat H. pylori through a triple therapy. Now, if they were taking NSAIDs, so what did you do? You stopped their NSAIDs. If they had H. pylori infection, what did you do? You got rid of the infection by giving them triple therapy. If they have ZE syndrome, get rid of ZE syndrome by either removing the tumor, or you could give them proton pump inhibitors, because they are also good for ZE syndrome. Now, this was the brief treatment of peptic ulcer diseases. Now, one thing that is very important when we talk about peptic ulcer disease is basically the complications, because the complications can be life-threatening, right? Yes. So let's talk about the complications. Two complications are very major. The first one is bleeding. Now, how can the ulcer bleed? So we're gonna talk about bleeding in two different parts: gastric ulcer bleeding and duodenal ulcer bleeding. So let's say if we have a gastric ulcer, where is it gonna be? On your lesser curvature. Go and think about the anatomy. Your lesser curvature is supplied by your left gastric artery, while your greater curvature is supplied by your right gastric artery. So if you have a ulcer on the lesser curvature, there are chances that ulcer is going to encroach on your left gastric artery and cause bleeding. So left gastric artery is going to bleed, right, in cases of gastric ulcer. If you have duodenal ulcer, now in that, this is where the anterior and posterior involvement of your duodenum comes into play, because if your duodenal ulcer is on the posterior wall, you have a gastroduodenal artery running. So duodenal ulcer on the posterior wall can cause the gastroduodenal artery to bleed. And also behind there you have your pancreas. Now, if the ulcer goes into your pancreas, it can cause pancreatitis as well. So these are the two things that can happen. You can either have bleeding from the gastroduodenal artery, or you could also have pancreatitis, because behind your duodenum you have pancreas. So you can also get pancreatitis. Yes. Now, coming on to I'll just erase this. Yeah. Over here. Now, let's say that you have you're done with bleeding. Now, the second complication that you can have is perforation. The ulcer can perforate. Over here, the ulcer can perforate from your lesser curvature, right? It can perforate from your lesser curvature on your stomach, and if it's on the anterior wall of your duodenum, you have higher chances of perforation. So I said that keep in mind the anterior and posterior wall of your duodenum will come into play later on. So if your posterior wall is involved, I'll write posterior here. Yeah. Posterior wall is involved, you will have bleeding from your gastroduodenal artery. If you have your anterior wall involved, you will have perforation of that ulcer. So this is where the anterior and posterior wall significance comes into play, right? And if the ulcer perforates, then the patient is going to come to you in the emergency department with acute abdomen. They're going to have peritonitis, they'll be hypotensive, tachycardic, they're gonna come into you in the emergency. So you need to treat them very well, because that peritonitis can cause death as well. It can spread. The patient is going to have absent gut sounds, and you will be able to see beneath your diaphragm due to a perforated ulcer. So these were a few things that are really important when we talk about peptic ulcers. So just to give you guys a recap, we talked about peptic ulcers, what is an ulcer, what is an erosion, the different kinds of ulcers that we have, the causes of ulcers. We talked about the whole mechanism as to how each causes you to have an ulcer. We talked about symptoms as to what would be the differentiating symptoms and signs in a patient who has either gastric ulcer or duodenal ulcer. We briefly touched upon investigation, and we briefly talked about the management. Management is very extensive, but we briefly touched upon it. So I hope that you guys are clear on this concept of peptic ulcer disease. And if there are any questions, feel free to write them down in the comment section or reach out to us on our Facebook page. But stay tuned for more videos and keep watching Excemy Medical. Why do they have